Good morning. I'm Professor Byung-Woo Yoon, Seoul, Korea. Whereas hemorrhagic stroke decreased annually by 1.82%. The proportion of ischemic stroke increased from 43% in 1995 to 65% in 2003. This pie graph shows the distribution of stroke by type. According to a paper published in 2019, ischemic stroke comprises 76%, subarachnoid hemorrhage 8.9%, and ischemic intracranial intracellular hemorrhage 14.5%. The paper revealed the stroke severity at admission. Admission NIHSS of ischemic stroke was 3, which is the median value with the interquartile range of 1 to 7. Admission Glasgow Coma Scale of hemorrhagic stroke were 13 in ICH and 14 in SAH. This is a graph showing the trend of stroke mortality. The death rates were 79.7 in 2001 and 53.2 per 100,000 in 2010. Age standardized stroke death rate has dropped by 28%, and risk factors of ischemic stroke. Hypertension is the most prevalent risk factor, and diabetes, smoking, and atrial fibrillation. Recent study published in 2020 shows the much higher proportion of dyslipidemia, 27.7%. We may speculate the reason of the discrepancy. It is possible that the actual number of patients has increased, or more blood tests might have detected the patients. Finally, different criteria of abnormal blood tests. This table shows the subtypes of ischemic stroke in Korea. Large artery atherosclerosis is the most common subtype, 33% of the 2014-2018 data from Korean Stroke Registry. Cerebral cardioembolism and the small vessel occlusion account for 20% each. More than 22% were categorized as a stroke of undetermined etiology. 2 or more etiologies were found in 5.4%. Negative results, despite the full workup, was 10%. Incomplete workup, 7%. This graph shows the changes of stroke subtype during the past 15 years. Large artery atherosclerosis has decreased from 36% to 32.6%. Small vessel occlusion dropped from 25.4% to 20%. In contrast, cardioembolism became more frequent, 17% to 21%. Now, let me talk about the management of stroke in Korea. For the diagnosis of stroke and its etiology, MR imaging is the most commonly performed tool. 95% of the patients undergo MRI diffusion-weighted imaging in 94%, MR angiography 88%. CT scan is done in 65% of the patients. TTE 76%, TEE 13%, Holter recording 30%. Transcranial Doppler 79%, and carotid Doppler 30%. Hyperacute stroke management improved significantly during the past decade. Early visit to ER less than 3 hours increased from 25 to 34%. Any thrombolysis, including IV RTPA and or intraarterial thrombectomy, 6.8 to 15.3%. And the number of intraarterial thrombectomy only is rising too. Introduction of intraarterial mechanical thrombectomy has improved the outcome of the ischemic stroke. This is a Kaplan-Meier curve of 1 year mortality. You can find the statistically have improved significantly. 1 month's mortality of ischemic stroke was 6.2%, and the hemorrhagic stroke was about 24%. The last part of my talk, KSR, Korean Stroke Registry, and the stroke care system. Let me briefly introduce the history of Korean Stroke Registry. In 1995, Stroke Registry sprouted in one hospital, Halim Stroke Registry. And the Korean Stroke Registry started the first generation of Korean Stroke Registry in 2001. 33 hospitals joined the registry at that time. In 2006, another national stroke registry was established by CRCS, Clinical Research Center for Stroke, with the participation of 66 hospitals. CRCS is a government-funded 9-year research project from 2006 to 2015. I was the principal investigator of CRCS. Missions of CRCS are development of clinical practice guidelines for stroke, establishment of National Stroke Registry, and formation of a stroke research network. After the CRCS project was over in 2015, we agreed to merge CRCS registry and the first generation KSR. From 2017, the second generation KSR is managed by Korean Stroke Society. These are current status of KSR. 82 hospitals joined the registry, and the registered number of acute stroke patients is almost 138,000 as of August 31, 2021. This is homepage of Korean Stroke Registry. Korean Stroke Registry collects various clinical data, including demographic data, risk factors, stroke mechanism and stroke severity, acute stroke management and workup, and discharge status. Here, I would introduce the efforts of Korean Stroke Society to improve the stroke care. That is the quality assurance activity of the hospital joining Korean Stroke Registry. 82 hospitals participate in the Korean Stroke Registry. KSR set predefined quality indicators of acute stroke care. We are monitoring the input data from each hospital, and the monitoring results are reported to each hospital for improvement of treatment. This is a graph showing the average data of quality indicators during the period between February 2019 and May 2021. Brain imaging was obtained less than 60 minutes in 92.5%. Regarding IV thrombolysis, Median door to needle time was 39 minutes. TPA therapy less than 60 minutes after arrival was performed in 91%. Of the ischemic stroke patients who arrived at the hospital less than 4.5 hours from the onset, IV thrombolysis was performed in 56%. Intra-arterial thrombectomy was done in 20% of patients who arrived less than 6 hours after the onset. Median value of door to puncture time was 94 minutes. The medication data showed antithrombotics were given within 48 hours in 94%. At discharge, antithrombotics were prescribed in 97%. Anticoagulation was performed in 85% of the patients with atrial fibrillation. There are two tracks of system building for stroke care: government and academic society. Our government has designed 14 regional cardiothoracic centers. This map reveals the geographic distribution of the centers. Korean Stroke Society activity include the certification of a stroke unit. Since the beginning of a stroke unit certification by Korean Stroke Society in 2008, the number of hospitals with the stroke unit is increasing. This paper analyzed the acute care, stroke care during the period of 2013 to 2014 in Korea. Figure shows the regional distribution of acute care hospital. Green dots are hospitals with a stroke unit. Red dots are those without stroke unit. The authors concluded that regional and hospital disparities exist despite quite acceptable quality of stroke care. Expansion of a stroke unit, stroke center certification, and connection between stroke centers and emergency medical services are highly recommended. In accordance with these points, Korean Stroke Society is expanding certification activity. Following the initial activity of stroke unit certification, Korean Stroke Society has certified 70 stroke centers during the period of 2018 to 2021. In 2021, Korean Stroke Society is certifying primary stroke center PSC and thrombectomy capable stroke center TSC. PSC has a stroke unit and can perform IV TPA. If PSC can perform intra-arterial thrombectomy, it is certified as TSC. It is strongly recommended for all stroke centers to join Korean Stroke Registry. This is a figure showing the role of stroke registry in the cycle of quality improvement. Through the activity of stroke registry, you can measure the performance indicator, then QI initiatives, and finally, improved outcome. Now, I would like to conclude that for better stroke management, we need data collection, data analysis, data interpretation. Through these activities, we can monitor and improve the quality of acute stroke care. This is true either at the individual hospital or at the regional or national level. Building a robust stroke registry will be the first step towards good management of a stroke. Thank you for your attention.